Hey, good morning. Like she said, I'm going to talk mostly about some general principles in stroke rehabilitation. Our objectives today are just to kind of go over what physical medicine and rehabilitation is. A lot of people don't even really know what we are as a specialty. We'll also go over some qualifications for inpatient rehabilitation, as well as goals of stroke rehabilitation and complications related to stroke rehabilitation, and some outcome measures as well. All right, so what is physical medicine and rehabilitation? We are a fairly young specialty. We came around around the 1940s, late 1940s, during World War II, mostly because of the physical medicine aspect, which is just using modalities to help people recover from injuries, and the rehabilitation portion, which is the actual physical therapies, as well as the medication and medical management of folks with functional disabilities, came around during the World War II era. We're also known as physiatrists or physiatrists, depending on what part of the nation you come from, and that's actually a really big issue in our field, how to pronounce it. And then for short, physical medicine and rehabilitation. The primary focus of our field is to maximize functional outcome and improve quality of life. Our area of expertise, like I said, is functional outcome in the patient as a whole. So we do look at all domains, including medical disabilities, psychosocial issues, and functional capabilities in these patients. We do prescribe medications and therapies, and we use the team approach, which is becoming more and more common in the field of medicine, to become interdisciplinary. Our focus is typically, just like any other medical field, on the chief complaint, and based on that we need to know what the patient's prior level of function is, as well as their current level of function, so we can come to a compromise with the patient and meet their current goals with their current level of functional ability. And so the most important thing to a physiatrist are what are current barriers to functional recovery and barriers to reintegration into society. In order to qualify for rehabilitation, if many of you have tried to place patients in rehab hospitals, there are a lot of check boxes you have to meet. And these are just an example of the criteria that our department uses for qualifying for inpatient rehabilitation. It's a huge list, and I won't go through all of it, but for the most part you do have to have functional goals and the need for interdisciplinary treatment. And so most patients will need to have continued medical care under medical supervision in a hospital setting, as well as the need for at least 2 therapy disciplines, which can be a combination of physical therapy, occupational therapy, or speech therapies. So at least 2 of those disciplines to qualify for inpatient rehabilitation. They also need to be medically stable for a stroke patient. Blood pressures need to be under reasonable control, which is oftentimes difficult because blood pressures do fluctuate acutely after stroke, but they do need to be essentially free of IV medications. Pain management needs to be under control orally. They need to have good access for nutrition, PEG tubes. We don't care for NG tubes, but we'll do them if we have to. Just anything that will get in the way of the rehabilitation process, IV poles, NG tubes, things that can get tugged out during rehab, are things that we prefer to be discontinued prior to inpatient admission. And they have to have reasonable inpatient goals as well. If it's somebody who has a very, very severe stroke and is very low level, our goals are very limited inpatient-wise, and they may benefit from a more subacute setting until they are able to participate in a total of about 3 hours of therapy a day. And so they do need to be able to do 3 hours of therapy, or within a short period of time reach that goal of doing 3 hours of therapy daily to meet inpatient rehab criteria. And so for physiatrists and for inpatient rehab hospitals, you do have to have certain diagnoses to meet your inpatient rehab patient population, there's 13 diagnoses that are our qualifying diagnoses. We have to have at least 60% of our patient population has to be one of these 13 diagnoses, and stroke is our number one admission to most rehab hospitals in the nation. So it is a big deal to remember that stroke patients do qualify for inpatient rehabilitation for the most part. And the theory behind stroke rehabilitation is the theory of neuroplasticity, which just means that with repetitive functional activities, there is the ability for neuronal reconnection and redistribution and uncovering latent areas of the brain to recover function after stroke. And that's the main theory behind stroke rehabilitation, is this idea of neuroplasticity, that the brain can make recovery after stroke, regardless of how severe it is. And in order for the brain to do that, it needs constant stimulation from an active environment, which can be in a rehab setting, it can be in a subacute rehab setting, it can be from home as well, and it can be through the environment, and typically a combination of the two. There we go. There are several studies that show that the earlier the onset of the rehabilitation process, the better the functional outcome in these stroke patients. And so the rehab process can begin when that patient enters the door of the acute hospital setting. It can begin by early consultation of physical therapists, occupational therapists, speech therapists. It can begin by early education of the family as far as stroke management and expectations of recovery after stroke. And so the rehabilitation process isn't just the inpatient rehab and the outpatient rehab. It's also the education of the patient and the family as soon as they walk in the door, because that's important to develop a motivated patient and family for success in the long-term rehabilitation process. All right, so functional enhancement is done by maximizing the patient's independence, improving their lifestyle, and improving their dignity, which is very important in most of these patients, is to return to their prior level of function or as close to it as we can. And we need to do that in a respectful environment, which involves education of this patient on what their expected level of function will be. We need to focus on physical, behavioral, cognitive, social, vocational, what they did prior to this for a living, anything we need to do to provide them adaptive equipment to reach those functional goals, and then re-education of the patient and family on current level of function and expected level of function after the rehab process. Our rehab team includes multiple disciplines, and our focus is on speech, language, and cognitive training, which is especially important to these patients. Mobility training, training on activities of daily living so they can provide their own self-care or be as independent as they can with their self-care. Arranging for peer support so they have psychosocial support in the community if they don't have a strong family support. Also family education, which is also very important because oftentimes these folks become the primary caregivers to patients with severe disability. And then if there's problems with swallowing or dysphagia, swallowing programs, outpatient feeding programs, and then most importantly to most of our patients is, when can I drive again? And so knowing where your access to a driving evaluation or driving rehabilitation program is very important, because you will get asked that question at some point. And then knowing what outpatient and home health therapies are available for these patients are very important. So this is just a short list of the team members involved in the rehabilitation process. The team leaders are your patients and your families. They guide the rehab process because they are the ones that set their goals. And they are helped by the physiatrist, so the physical medicine and rehab physician, any of the consulting physicians, and other team members like the rehab nurses, physical therapists, occupational therapists, speech therapists, chaplains, nutritionists, registered dietitians. Our therapeutic recreation specialists are also very important because they help with that dignity and quality of life aspect during the rehabilitation process. Neuropsychologists are important with the rehab process also to help with adjustment and anxiety related to their new functional level. And so it's a very big team, and this is just a short list of who's involved. And again, like I said, the patient and the family are the team members for the rehabilitation process. All right, so how do we measure improvement? We use the functional independent measures as our measure of how patients improve during the rehabilitation process. It's a big scale that ranges all the way up to, I believe, 126 points. It involves mobility, it involves scores on self-care, it involves scores on toileting and sphincter control. It also involves scores on speech and cognitive abilities to reach that score of 126. And it ranges from a patient who is requiring total assistance for all of those to somebody who is completely independent. And it is a validated scale that's used throughout most accredited rehabilitation hospitals. So we have some kind of objective measure on how these patients are making improvements. For mobility-wise, that's one of the biggest problems these stroke patients have. Up to 88% of stroke patients have some degree of hemiplegia or hemiparesis. Most of their recovery occurs within the first month, and a large portion of that occurs within the first 3 weeks after stroke, with most of your recovery being seen within the first 6 months after stroke. And so it's really important, because a lot of that acute recovery happens early within that first 3 weeks, that the rehabilitation process begins early so we can take advantage of that rapid recovery. The typical recovery pattern includes the leg recovering before the arm, and then the arm recovering. And it also occurs proximally, so shoulder will come back before the hand. So usually the most important things to a patient, the ability to use fine motor skills, those are usually the last things to come back. And then typically through this stroke recovery, you also will see a pattern of spasticity develop as they go through recovery, where they'll go through a flexion synergy pattern where arms and legs will draw up, and then as they recover through that, then they'll be able to extend out of that. And so that's typical stroke recovery, and that's in typically a MCA distribution stroke, which is the most common stroke that we see on the rehab floors. And so stroke recovery, usually one of the biggest prognostic indicators is the severity of the stroke and the severity of your functional disability after acute stroke, particularly with arm weakness. 9% of these patients with a severe stroke, which is total hemiplegia after stroke, will have hand recovery long term. And so it's not a very large number. Usually you will have some deficits with fine motor lifelong with that hand. Timing of the motor recovery in the hand is also very important. If it doesn't occur within the first 4 weeks, chances are you won't get much recovery. I think about 70% of these people will have full to good recovery if they start seeing motor within their hand within that first 4 weeks. Otherwise, you will have prolonged lifetime trouble with fine motor in your hand. Things that are poor prognostic indicators that we see on the rehab ward: proximal spasticity, so spasticity in the upper portion of the limbs, hips and shoulders, because if they have spasticity there, it's hard for them to overcome those spastic patterns to use the distal portion of their limbs. If they have prolonged periods of flaccidity, so if their hemiplegic side is flaccid for usually greater than 3 to 4 weeks, chances of recovery are not as good. Also, later return of proprioceptive responses, so difficulty with sensation or knowing where your limb is in space. Late return of that is also a poor prognostic indicator of future ability to use your upper extremity, your hand, and for ambulation. And then late return of proximal traction response within the initial 13 days. Which is your push to pull in that upper extremity. So those are some poor prognostic signs that you can see acutely that will indicate likely poor return of motor function and decreased ability to ambulate in the future. And so again, we do have some stages of stroke recovery that we use in the rehabilitation setting. It's called Brunnstrom stages, of course named after somebody. The first stage, which you often see in the acute side, is the flaccid stage, so no motor return, poor tone. And then you should get spasticity returning. Usually within the first 48 hours, you can start seeing spasticity in the limbs, where you can start getting the flexion synergy patterns where their arms and legs start drawing up. And as the stages progress, the spasticity gets worse until they reach about the stage 4, which is usually when we get them in the rehab setting, where they can start coming out of those spastic patterns and breaking out of the spastic tone in their limbs to become more functional users of those limbs. So most of our traditional therapies in the inpatient rehab setting include positioning and range of motion, which is also something that is very important to begin acutely after stroke, especially if somebody is severely hemiplegic. Immediate mobilization, if possible, starting to get these patients out of bed or at least sitting upright in bed in the acute side is also very important. Teaching these patients and their family compensatory techniques, using their good side to help feeding or using assistive devices to help with self-care activities is important, as well as strengthening endurance exercises to help build strength in their good limbs, as well as trying to improve what strength they have in their affected limbs as well. So for stroke rehab, the exercises are going to emphasize repetitive movement because that's important for neuroplasticity, importance of sensation for control of movement to help improve your fine motor skills and coordination, and developing your basic motor movements and postures to help regain normalization of your motor movements, normalization of your arm movements, normalization of your ambulation and gait patterns. And so there are several theories of rehabilitation that we use in the rehab setting. The neurodevelopmental technique is the most commonly used in the rehab setting, and it just emphasizes inhibiting primitive reflexes and improving postural control to help regain and to help normalize your movement patterns. But there are also techniques like the Brunnstrom technique where we utilize the spasticity patterns to help with daily care. For instance, utilizing spasticity in the upper extremity to help get your hand to your mouth to help feed yourself. And there's also techniques where you use proprioceptive training to help with sensory control of the limbs as well. But nowadays we are using a combination of all these techniques to get better recovery because there really hasn't been any study that shows that one of these techniques is better than the other. So a combination of these techniques is what is used in most rehab settings. And so now on to more of the fun things about the rehab process. So some special therapies and modalities that we use in the rehab setting after stroke, and especially in most of our neurorehabilitation patients like brain injury, spinal cord injury, we use these techniques, but stroke patients usually get the benefit of all our toys. And so functional electrical stimulation, my patients call it shock therapy. It's little devices that provide electrical stimulation to peripheral nerves and muscles to help create muscle stimulation and motor movement patterns. We can use it on the arms to help with gross grasp. We can use it on the legs to help with foot drop to help normalize their gait patterns. They love it because when they're using these, they have more normalization of their movement patterns, so they think that it does improve their time to recovery. And it's one of the more techie things we do in the rehab setting. And there also been several studies that actually, I think the most recent one was in 2010 in the Physical Medicine Journal, that actually do support the use of this technique in improving the speed of recovery during the rehab process, and it does show prolonged effect. So the use of neuromuscular electrical stimulation does show prolonged effect of functional outcome in these patients. And so it's something that we use commonly after stroke. Mirror therapy is also something that is initially was kind of a fad in the rehab setting, but it's becoming more and more common. The patients really enjoy it. It was initially done with amputee patients, and we're starting to see it now more and more with patients with hemiplegia. It's used in treating hemiplegia, especially those with severe neglect, so those patients who are ignoring their hemiplegic side. And the theory behind this, as well as the neuromuscular stimulation, is recreating those neural pathways, neuromotor sensory pathways with that theory of neuroplasticity. And then dynamic splinting, and so using splints and braces to take advantage of what function they have. This particular one on the upper corner, the blue one that looks kind of Robocop-ish, is one of the newer ones out. It's a Sabo splint. What these splints do is it allows the patient to use what function they have. So if somebody is able to use their finger flexors to grasp, the splint will let them use that function, but it will compensate for what they're lacking. It'll compensate for their extension. So it will allow them to have release of their grasp. So the nice thing about these dynamic splints is that it allows the patient to be functional and to be more independent despite having lack of extensor control or flexor control. And so we have dynamic splints made for mostly for upper extremities to use for flexion or release of grasp to help with increased independence with self-care like feeding and grooming and bathing. And then one of the more old school therapies that a lot of our patients don't like is constraint-induced therapy or forced use of their limb. This is mostly used in patients who have at least trace to anti-gravity strength in their affected side. What we do is we literally tie down their good side and make them use their hemiplegic limb. They can't stand this because it makes a mess when they're feeding themselves. It's frustrating. But it also works under that theory of neuroplasticity. Repetitive functional movement will help recreate those neuronal pathways to help with neuronal recovery and recovery of those motor movements. But it is not one of their favorite things to do. And then ambulation assistive devices are used with most of these patients, and they range from straight canes to canes with this small quad bases to walkers to hemiplegic walkers where we have a platform to support the hemiplegic arm. You can also use bracing. The braces on the bottom are called ankle-foot orthoses. Those help support weak ankle dorsiflexors to prevent foot drop and toe drop or drag, to help normalize the gait pattern so that they're able to ambulate more efficiently. And a lot of patients will be able to community ambulate with these devices. And then complications after stroke. And so these are problems that can be encountered during acute hospitalization that can be prevented to make the rehab process easier. So this is really selfish on my part, is to educate you guys on things to do early on and acutely to make my job easier. But these are also things that we run into in the rehab setting that can hinder patients' functional recovery in the future. And so hemispatial neglect, it's a pretty big problem in some of the large MCA strokes, some of the larger strokes. It's a deficit to attention and awareness of the one side in space. And about 3/4 of stroke patients will have some kind of neglect. And usually it's about 20 to 58% of these patients. And so it's a big range of patients, but it is something that can hinder the rehab process because they are unaware of that side. So it does hinder some of our neuro rehab facilitation techniques because it has decreased awareness of their deficits. And when you have decreased awareness of your deficits, it's hard for us to have you work on that side. Patients with neglect take longer to recover because of these, because they have decreased insight into their deficits as well. And they require longer therapeutic efforts. So length of stay in the acute care setting is longer, length of stay at the rehab setting is longer, and then length of therapy needed outpatient, home health or outpatient is also longer. So the rehab process is much longer with these patients who have neglect. Techniques for treating neglect. One of the easier things to do is just scanning. We have them scan towards the side of neglect. We use trunk rotational therapy, which is part of that neurodevelopmental technique, to work with the patient's postural control and turning to help facilitate scanning. Using eye patching to make them use, it's another form of constraint-induced therapy, to make them use that neglected field. And then also prism glasses, which bring that neglected side into their field of vision. Constraint-induced therapy again, mirror therapy is important. And then neurostimulation medications like amantadine and methylphenidate and bromocriptine have also been shown to improve recovery of neglect in these patients. And then falls is a significant complication after stroke. It happens in the acute side as well as the rehabilitation side. Risk factors for falls are multiple. Folks with right-sided stroke, so folks with left-sided hemiplegias, are more likely to fall than folks with right-sided hemiplegias. People with neglect are more likely to fall because of their decreased awareness. People with bilateral strokes, people with severe cognitive impairments and confusion, the male gender, folks with male gender, oftentimes these patients are more impulsive than the female patients after stroke. And then anybody who has trouble with bowel or bladder incontinence and poor communication. And then those patients who are requiring the use of sedatives or diuretics also are at increased risk of increased risk of fall after stroke. And so things that you can do to prevent falls are adequate staffing if possible, decrease the use of sedative medications if you can, initiation of the early rehab process for strength training, and also timed voiding is very important with these patients, because a lot of times these falls are related to patients needing to use the restroom and they're just unable to communicate. And so time voiding in the rehab setting has been shown to decrease fall risk significantly. And then if you need to, bed alarms and restraints with frequent staffing to prevent falls in these patients. Then shoulder issues are a big problem that we see in the rehab setting, both inpatient and out. Problems can include subluxation, which is just loosening of the joint because of the weakness in the muscles, and traction neuropathy, bicipital tendonitis, so overuse tendon injuries in these shoulders, impingement signs, frozen shoulders, and then complex regional pain syndrome, which is just a neuropathic pain syndrome that occurs in these patients. And the most common ones are the subluxation and the overuse injuries like bicipital tendonitis and rotator cuff injuries. And these can be prevented by adequate positioning of the hemiparetic limb. And so treatment, like I said, proper positioning, shoulder braces can be used to help position the limb, arm troughs with wheelchairs, and you can also use functional electrical stimulation to help stimulate those muscles to hold the shoulder in the appropriate and appropriate place. And then if all else fails, medications and injections to decrease pain as well. And then dependent edema is a big source of problems in the acute rehab setting also. But you do need to rule out DVTs in this patient population if you do see this, because it is also very common, especially within the first week of presentation after stroke. Treatment includes, for dependent edema, range of motion exercises, limb elevation, sequential compression devices, and then compression stockings or TED stockings to help decrease that. and then massage also. And the problem with edema in the rehab setting is it causes heavy limbs. It also causes pain. It can increase your chance of developing complex regional pain syndrome or neuropathic pain syndrome in that limb. It can cause skin problems, and it can cause us to have difficulty fitting orthotics like an ankle brace or AFO. So it can actually limit function if it's not treated. And then spasticity, like we mentioned earlier, its onset could be days to weeks, usually within the first 48 hours in some cases. It usually in the upper extremity is in a flexion pattern, so your arm will draw up. In the lower extremity, it's an extension pattern, so you'll have an extended hip, knee, and your ankles will be plantar flexed or your toes will be pointed. Spasticity is velocity dependent, and so it is exacerbated by rapid stretch. So when these patients are being transferred from bed to chair, or when they're being adjusted in bed, if they're moved rapidly, if the limb is moved rapidly, it can actually exacerbate their spasticity and tone and cause pain. And so it's something to be aware of. It is velocity dependent. So those hemiparetic limbs would need to be moved slowly and with sustained stretch when you're working with them. Treatment-wise, we use slow sustained stretching. It's our first line of treatment. It helps if these patients have slow sustained stretching right before a transfer to prevent exacerbation of spasticity. We can also use splinting to help prevent this. Resting hand splints and resting ankle splints are important in the acute care setting to prevent spasticity from causing contractures and deformities that can hinder the rehab process and functional outcomes later. You can use serial casting to help put patients back into proper positioning. You can also use heat and cold to decrease spasticity in the muscles. And then medication-wise, we use baclofen, tizanidine, and benzodiazepines frequently to help as muscle relaxers to decrease spastic tone in these patients. And then in the long run, if this becomes a problem, botulism toxin injections and phenol injections, or if it's bilateral lower extremity spasticity, intrathecal baclofen pump infusions are also helpful for spasticity management. And if needed, surgery to help improve or decrease contracture and improve limb positioning. And then DVT, like I mentioned earlier, anybody who has lower extremity swelling or any extremity swelling needs to be evaluated for DVT because it does occur in about 20 to 75% of patients after stroke. And most of the time it is in the hemiparetic limb, although it has been seen in the unaffected side as well. And then pulmonary embolus occurs in 1 to 2% of these cases. And if it does occur, most often it occurs within that first week after the acute stroke. And so in the rehab literature, it is recommended that all patients after acute stroke who have any sort of motor weakness be placed on DVT chemoprophylaxis with either subcutaneous heparin or low molecular weight heparin to prevent DVT acutely. You can also use SCDs, like I mentioned earlier, for treatment of edema as well, and then compression stockings or TED hose. All right, and then bladder dysfunction is a big deal. It's also a huge deal for families who are going to be primary care providers after the patient is discharged home. 50 to 75% of stroke patients will have urinary incontinence during that first month after stroke, and then about 15 to 20% of them will continue to have urinary dysfunction after the first 6 months to a year after acute stroke. And the voiding problems are multiple. It can be uninhibited bladder, it could be a reflexic bladder, so a flaccid bladder, and it also could be bladder outlet obstruction or dysynergia, so you have increased tone, increased bladder sphincter tone, preventing voiding as well. And so your treatment needs to be what the underlying cause is. If it's a spastic bladder, you need to treat the spasticity. If it's a reflexic bladder, you need to treat the volume control, and it may require in and out catheterizations or Foley catheter placement in the short or long term. Medications can also help. And then education of the patient and the family is also very important. And then this is especially important in the acute care setting. You do need to be aware that bladder dysfunction is fairly common in this patient population. So if you remove a Foley catheter acutely, you do need to be checking post-void residuals either via ultrasound or with intermittent catheterizations to ensure that the patients are voiding adequately to prevent long-term problems with the renal system. All right, and like I said, the incidence of incontinence is big, both bowel and bladder. So with bowel, incontinence happens within about 30 to 40% of these patients, and its recovery pattern is similar to bladder recovery. It happens within the first 2 to 3 weeks, typically. And usually decreased continence usually is related to decreased mobility or communication. So patients who are severely hemiparetic or patients who are severely aphasic are the patients who are having the most difficulties with bladder and bowel incontinence because of their inability to communicate their needs. And so the first-line treatment for both bowel and bladder is time voiding because of these patients' inability to voice their needs. Constipation is also pretty common in this patient population, and it's just treated as you would anybody with constipation, improving your fluid intake and fiber intake, as well as stool softeners and medication management for bowel control. And then dysphagia, overall incidence, 30 to 45% of these patients will have trouble swallowing. It's important to know the signs and symptoms of swallowing because the complication of aspiration pneumonia is pretty significant and is one of the number one complications after stroke, aside from falls. And so signs of an abnormal swallow is somebody who has an abnormal or weak cough or voice, somebody who coughs after they swallow, somebody who has dysphonia, somebody who has a soft voice, somebody who has difficulty speaking or some kind of dysarthria or slurred speech, somebody with an abnormal gag reflex, or somebody who has problems with voice changes after they swallow, so if they have a wet quality to their voice after they take a sip of water, and somebody who has difficulty handling secretion, so somebody who is unable to manage their saliva. And also something that's not listed here is somebody who has facial weakness and is pocketing their food. They're also at increased risk of aspiration if they have facial weakness causing pocketing of their food. And so, unfortunately, about 40 to 60% of swallowing problems are missed on bedside examination. And so it's important to do your bedside examination, but you also need to be cognizant of all these other signs and symptoms of swallow problems. And most of these patients will benefit from a formal swallow evaluation with either endoscopic evaluation or the video swallow studies with the barium swallow, so that you can actually see the anatomy and see how the anatomy is working and if the coordination of the anatomy is intact. So aspiration pneumonia is the biggest problem in patients with dysphagia, and so you do need to be aware of risk factors. So patients with decreased level of consciousness are significantly increased risk of having an aspiration pneumonia. They may not necessarily have problems with dysphagia, but if you are not alert enough to have an adequate and safe swallow or adequately take in a full meal, you are at increased risk of aspiration. Patients with tracheostomies, patients who have vomiting, patients who have reflux, somebody who has an NG tube in place is also at risk for aspiration pneumonia, and then again, patients with dysphagia. Treatments for dysphagia, one of the easiest things you can do is changing the position of the head. Make sure the head of the bed is elevated. You can make sure that they're fed in the upright position. Using the chin tuck will help get the swallowing anatomy in the right position to help decrease risk of aspiration. Turning your head towards the plegic side will help decrease food pocketing, as well as help control the food bolus in the right direction. Diet modification, changing them to a puree diet or a mechanical soft diet, or changing liquids to honey thick or nectar thick to help them have better oral and pharyngeal control of the food and fluid boluses. And then evaluation and treatment by a speech therapist using oral motor exercises, and sometimes even functional electrical stimulation of those swallowing musculature to help with dysphagia. All right, and then aphasia is also a problem after stroke. It's the impairment of the ability to use Lai's language after some kind of brain injury or insult. It can cause impairment in reading, writing, and problem solving. If a patient has aphasia, it does increase their length of stay acutely and during the rehab process. And it decreases your rehabilitation efficiency because of their decreased understanding of the rehab techniques. So they have impaired carryover of our rehab techniques. About 40% of patients have this, for depression, about 40% of patients have problems with depression after stroke. Most patients that present to a rehab hospital will end up on antidepressant, an SSRI, usually short term, but it may be long term. It may be related to neurotransmitter deficits after stroke, but it can also be related to just having a functional deficit or change in functional level after stroke as well. So it could be related to anxiety and an adjustment disorder as well. Risk factors for depression and mood disorders after stroke include the female gender, prior psychological history, severe impairment, so the severity of stroke is important, non-fluent aphasias, and the lack of social support is also a big issue in having some kind of mood disorder after stroke. Somebody with persistent depression is going to have delayed recovery after stroke and poor functional outcome. And your mainstays of treatment are neuropsychological assessment in the rehab setting to help with adjustment and anxiety counseling, and medications. And then seizures after stroke. Anytime you have any kind of insult to the brain, you are at increased risk of seizures. And they are classified as early onset and late onset and acute onset. Usually they occur from some kind of metabolic derangement after stroke and not necessarily from the stroke itself. Stroke patients who require inpatient rehab are usually more likely to have some kind of seizure or develop post-stroke epilepsy, and these are usually because these patients have a more severe deficit after stroke or a more severe stroke. If the seizure occurs within the first 2 weeks after stroke, they are at increased likelihood of recurring. So if you have an early onset of seizure after a stroke, you are more likely to develop long-term post-stroke epilepsy. And then treatment-wise, these patients, so all stroke patients need to be placed on seizure precautions and anticonvulsants if they do develop seizure activity. Then most importantly, outcomes and will these patients return to work? The most reliable predictor of functional outcome during rehab is the patient's functional ability on admission. And so the severity of the stroke is very important to their long-term functional outcome. If their admission functional outcome measure score is greater than 60, so if they are requiring little assistance or minimal assistance with mobility and activities of daily living, sphincter control, and speech and language, they're more likely to have better functional outcomes, and that's intuitive. Any patient with persistent urinary or fecal incontinence usually have difficulty with placement issues after the rehab process, and oftentimes it's because the family members have trouble with providing this type of, this amount of care with these patients. And a lot of times if there is persistent urinary and fecal incontinence during the rehab process, these patients will require a subacute or post-acute rehab setting or a skilled nursing facility at discharge. And this is usually because of lack of social support. And then your discharge disposition and your outcomes after stroke are related to many things. Just your initial ability after stroke and your urinary and fecal incontinence are the two big issues of functional outcomes and discharge disposition after stroke. But many things play a role. Severity of stroke, how old you are when you have this stroke, if you have severe neglect after stroke, your social support is very important, your ability to do your self-care tasks, your activities of daily living. If your aphasia is severe, these are all things that are going to play a role in your functional outcomes and your eventual discharge disposition, whether you go home independently, home with family support, or to a post-acute rehab setting or skilled nursing facility. There actually has been a very large study done in Sweden, the Copenhagen Stroke Studies, that predicted functional recovery after stroke. They did show that 63 patients who presented with impaired walking, about 22% did not regain the ability to walk of those that survived their acute stroke. 66% of them achieved independent walking, and 95% achieved their maximum walking function at about the year point. Most of this recovery was seen within the first 3 to 6 weeks after their acute stroke, and usually by this 6-month point, you've seen your maximal amount of recovery. The most common problem with ambulation after stroke is foot drop or weakness of your ankle dorsiflexors, and so most of these patients did require some kind of orthotic or assistive device to help normalize their gait patterns, and the most common equipment used after stroke was a ankle foot orthosis, or an AFO, to help prevent foot drop and toe drag to normalize their gait pattern. Some negative factors that affect return to work: low score on the Barthel Index. This is a scale that was used in the Copenhagen Stroke Study. It's similar to the FIM scale, the Functional Independent Measure scales that we use here in the U.S. So it looked at ability to provide self-care, your activities of daily living. It looked at mobility, and also looked at sphincter control and speech and cognition. The longer you stay in the rehab setting, the less likely you are to return to work. The more severe your aphasia or the presence of an aphasia, the less likely you are to return to work. And any history of prior alcohol use, the less likely you are to return to work. And a lot of this is due to your premorbid function secondary to alcohol use, as well as premorbid damage to the cerebral cortex from the alcohol, which will impair post-stroke recovery. And methods we use to help patients return to work, aside from improving mobility and self-care, neuropsychological testings to determine specific areas of deficits, especially cognitive deficits, so that we can help make accommodations in the workplace. A lot of these patients who do recover that are pretty high level will oftentimes still need extra time for tasks and assignments and frequent cognitive rest breaks when they do return to work initially. We also use functional capacity evaluations to help determine a patient's functional ability, especially if they are somebody who does a lot of manual labor work. So we can determine any restrictions on lifting or moving or driving. And then oftentimes these patients, especially within that first year or two, will return to work with some kind of restriction, whether it's restriction on their mobility, the amount that they're able to lift, if they need extra time for tasks, or if they need extra breaks, or if it's just even part-time work. And so just to summarize some things that can be done from the acute setting to help facilitate the rehab process. You need to initiate the rehab process early. So consultation of physical therapists, occupational therapists, speech therapists, and rehab physicians at the onset or at the admission after stroke is very important to begin the rehab process. You want to prevent complications, so early range of motion and splinting to prevent contractures so that the limbs will be ready to use in the rehab setting. Shoulder slings and proper arm positioning to prevent shoulder pain, because that is a limiting factor during the rehab process. You want to have a high suspicion for dysphagia and trouble swallowing so that appropriate route for nutrition can be placed so that we can really be aggressive with the rehab process and not have to worry about how we're feeding a patient. It needs to be done early on during the acute hospital stay so we don't hinder the actual rehab process. DVT prophylaxis to prevent DVT and pulmonary embolus. And then you want to monitor their nutrition again with PEG tube placement early if delayed recovery is expected. And then you want to monitor for neglect in these patients and help the patients compensate for it. One of the easiest things you can do is make sure that their tray in their room their food tray is placed on their non-hemiplegic side so they can actually see and pay attention to the food and get their nutrition in. A lot of times these folks, if the tray is placed midline or to their hemiplegic side, they won't see it, they won't attend to it, so they won't get adequate nutrition, and even if they can feed themselves or don't have any problems with dysphagia. And also important is to try and avoid lines and IVs in that hemiplegic side because the patient is going to ignore that side, and they're also at increased risk of neuropathic pain or complex regional pain syndrome if there's any type of noxious stimuli, IVs included in that limb, and so that does increase their risk of having pain syndromes in their hemiplegic side in the future when they have lines and IVs in that side for a prolonged period of time. And then with bowel and bladder management, remember time voidings can help prevent falls, both acutely and in the rehab setting, and can increase the patient's dignity and quality of life because it's going to prevent incontinent episodes, and it's going to make the families feel more at ease with patient management if you can get those things under control. And if you discontinue a Foley catheter, please be aware of bladder problems in these patients and check routine post-void residuals and use intermittent catheterizations or replacement of Foley catheters if needed to make sure that the bladder is managed adequately. And that is it for stroke rehab. Any questions? This is often something we do in a course of 3 weeks with our residents, so it's hard to get all this information within 1 hour.
Do we have any questions? Does everybody have